right, ladies and gentlemen, thank you for waiting. Thanks for being here today. We're going to go ahead and get started. Um, Hopefully you can hear me. There is a Q&A box if you look at your Zoom menu bar. So at any point during the presentation, feel free to drop in questions. We'll have Q&A at the end, and we'll make sure we try to get to as many questions as possible. Happy Friday to you. Welcome to Coffee with Kevin. This is our, I believe, fourth version of Coffee with Kevin, first this year, Q1 version 2025. So we're excited to have everybody here today. This meeting is recorded, so while we do recommend you take notes and write down questions, we will also send you out a recorded copy or recorded version of the video here today, so you can watch it again if you feel so inclined. I realize that's not maybe the most exciting way to spend your next couple days, especially with the March Madness tournament going on. But we will record this and send it out. And I promise we will have you out of here before the first games tip off, and hopefully well before that. Won't be here too long. We do have an hour set aside. If we need it, great. If not, we'll end a little early, but we do want to always leave time for questions and answers. So we'll take about half the time to go through some information and the rest of it to answer questions. So without further ado, let's just keep on moving. It's out of the way here. Okay. So just again, my name is Kevin Chaikin, and I am the agent for many of you on here, where my team is your agent here. I'm the owner of Insurance Masterminds Agency. We are a partner of MP Group, which of course is a name you see quite a bit coming from us in our emails. For those of you that have been with us since the beginning, or at least, for longer than the last two to 3 years, formerly Medicare Portal. So same company, same great service, same group of people. Just had to make a little bit of a change from some due to some unclear regulations a couple years ago. So that's the same team, Medicare Portal, for those that have been with us for several years. And as a reminder, we are an independent Medicare insurance agency. This is all we do. This is the language we speak. We don't deal in under 65 healthcare, really. We don't do any other insurance, home and auto. It's all about retirement health insurance. And we are an agency that provides no cost education, enrollment, and of course that lifetime service while you're here and trying to keep you educated. And we are going to keep on doing that as long as you have a policy in place with us. Coffee with Kevin, this particular event, is a client exclusive or client only webinar, providing quarterly updates for you on what's going on with Medicare, things to be aware of. Excuse me, I'm just grabbing my coffee here. And remember, we work for you, not the insurance companies. So we're always here to make sure that you have the insurance, the health insurance is going to meet your goals and your needs, regardless of the company that's with. So, of course, many of you go through annual reviews or other times during the year where a change may be needed if possible. And if it's a different company, an insurance company, so be it. We're going to do whatever we can to make sure you're happy with your coverage and keep working for you as your agency. So all the ways to stay connected, just feel free to follow us. Of course, we have our personalized service that we offer throughout the year, annual reviews in the fall, and these quarterly webinars. You can also stay connected to us through our quarterly e-newsletters. If you're not getting these, but you want them, please either put your information in the Q&A or send me an email. If you don't have it, that will be available at the end of the slides. But that's something we send out quarterly to just keep you updated what's going on with Medicare in addition to the webinar. So of course, you're getting emails if you're here, but if you're not getting that newsletter, let us know. On social media as well, you can follow us, and there we just try to provide ongoing updates, whether it be updates related to news about Medicare, changes to the program, a lot of educational videos on Facebook, YouTube, TikTok, and Instagram. So feel free to follow us there, and I'd love to see you there and keep you abreast of what's going on. Stay connected that way as well. So the latest update, this is our footprint across the country. So of course, if you're here, you're in one of these states in blue, obviously, if you're a client of ours. But we show you this just so you know, we are expanding both for the sake of clients across the country, but as well as our team is expanding, adding agents to be able to help more people, whether that be helping you move to a new state and finding coverage or making adjustments for you in the new state that you may move to. as well as your friends, families, and colleagues around the country. We are, like I said, growing, and we are happy to take your referrals. We appreciate them. We love helping more people, and we have agents who are standing by, ready to help. We all work together very closely as a small team. My office here, just me and two other agents at the moment, who are focused on, again, delivering the same quality of service to every single Medicare beneficiary who comes through our door. So please, if you have anybody that's turning 65, retiring, or needs help this fall during annual enrollment, send them our way or let us know. Be happy to help and reach out. So, what you came for today, what are we covering? So, we're going to talk a little about what's changing in 2025. And of course, we're already, hard to believe, it's almost 3 months into the year. And so you're experiencing some of these changes already. Of course, we've heard from some of you with questions or concerns about things that maybe feel or seem a little bit different this year than they did last year or in years past. So we're going to talk a little bit about that. We will talk about enrollment periods, which it's not just about annual enrollment in the fall. Of course, that is the time all the advertising comes out and confuses everybody like no other. All of our good friends like Joe Namath and JJ Walker and Joe Montana and whoever else is out there confusing our Medicare beneficiaries, our seniors about Medicare. But there's other enrollment periods during the year that you should be aware of. They may impact you and they may provide you opportunities to adjust coverage as the year goes on. And as well as a future outlook on Medicare and the program itself. So, excuse me, just trying to make sure these questions are not, I just want to make sure you guys can hear me. No one was telling me that they couldn't hear anything. Okay, so future outlook of Medicare. And again, this is just kind of based on what's happened in the past couple of years, what's in store for 2025, 2026, and beyond. Some of our estimates on, just kind of where things are going. And then we're going to cover today something that we talk about a little bit, haven't done a great job talking about it in certain cases, and we'll dive into a little bit more, partly because some of this stuff depends on the state you're in, but planning for the unexpected. What are some of the exposures on Medicare that are out there and that may still impact you despite the coverage that we have in place for you? So we'll talk a little bit about that today. And then, of course, that live Q&A. So we have that Q&A box, and I see a couple people have already thrown some questions in there, which is great. So please just feed them into that Q&A feature, and we'll be happy to answer those questions at the end. Excuse me. I already had my coffee today, so I need to just focus on the water. All righty. So what is changing in 2025? So some kind of by the numbers, right? Part A deductible, that's your inpatient. Remember, Part A, some of this stuff, of course, is just 101, but we speak it every day, and I don't want to take for granted the fact that you don't. Why should you or would you, right? So we'll just kind of recap on what some of these things are. So Part A, that's your inpatient coverage. Think of that essentially as your room and board in a hospital, psychiatric hospital, skilled nursing facility, covers some home health care and hospice as well. That Part A deductible for an inpatient admission is $1,676 this year. For hospital stays, these are the costs on original Medicare. For days 61 through 90, $419 per day. Days 91 through 150, which includes your lifetime reserve days, $838 per day. Right, so these are some of the exposures already that we're always focused on protecting you from. And again, if you're on this call, you're a client of ours, these are not necessarily exposures that you are going to face today, especially those first three. Now, skilled nursing facility, Medicare covers those first 20 days, but after that, 21 through 100, it's $209.50 per day. Again, if depending on your coverage, you may not be exposed to any of that 209.50, could be part of it. But then after day 100, there is no coverage on Medicare for skilled nursing. So that is an exposure we'll discuss today as well. Part B deductible, $257. That's an annual deductible. So as opposed to Part A, let me go back there. Part A's deductible is actually per admission, essentially per benefit period. So that can happen multiple times. The Part B deductible is a one-time annual deductible. And of course, Part B coinsurance. Now, most of these things listed here, majority of you are not going to be subject to all of them. If you're on a Medicare supplement, that Part B deductible is certainly something you're aware of. But as a reminder, if you got a bill so far this year, you thought your supplements covering everything, remember, you do have to pay that Part B deductible. On a Medicare Advantage plan, depends on your plan. You may or may not have a deductible. It wouldn't necessarily be $257. Many plans have no deductible, and you're paying more on the copay side. For those supplement folks, that Part A deductible, and Medicare Advantage folks, that Part A deductible is not something that you're going to be exposed to with the coverage we have in place for you. And then you may or may not have hospital copays and skilled nursing copays, again, based on the type of plan you have. 20% coinsurance on Part B, again, something that most of you on Medicare supplement are not exposed to for Medicare covered services. On an Advantage plan, it's not on everything for Part B like it would be if you just had government Part B only, but there is 20% coinsurance on certain things that will, again, cover a little bit later that can expose you to quite a bit. Now, for those of you on the for premiums here, so 185 is the Part B premium. So remember, if you're getting that bill from Medicare every 3 months, it's $555, or a deduction from your bank account or your Social Security of 185, that is the Part B premium. You do have to pay that. So unless you're potentially on Medicaid or have some assistance there, you are going to pay at least the Part B premium. Now, some of you may be subject to higher premiums based on income. That's IRMA, which is the income-related monthly adjustment amount. And as you may know, they look back 2 years. This traditionally or typically hits people, when you're first getting onto Medicare, because let's say you were working and then you retired. So your income has dropped. And there's a whole appeal process. If you feel like you're paying more than 185 and you shouldn't be, reach out, let us know. That reduction, the appeal has to be tied to a life-changing event like retirement, reduction in work, divorce, annulment, death of a spouse, loss of income-producing property, those types of things. So not everything is going to qualify you for a reduction in premium, but certainly if you think you're paying more than you should, let us know. You can see that Part B premium, though, gets pretty high. The less subsidized, all the way up to $628.90 per month. And then there is a Part D adjustment as well if you are subject to IRMA, which is tacked on to your plan premium. So we hear the question sometimes, well, why am I paying a premium to the insurance company and to the government for Part D? And the government never provides you Part D coverage, but they are going to go ahead and collect that income adjustment if you are subject to it. We'll cover Part D a little bit more detail here as we move forward. But the 185 is what most people will be paying unless you are subject to that income adjustment. Remember, that's not lifetime either. So maybe you don't have a valid appeal, the life-changing event, but they're going to look back 2 years every year. So at some point, if the income has dropped, then your income will be adjusted or your premium will be adjusted accordingly based on that 2-year look back. Now, Medicare Part D, this is kind of the main topic of the conversation here today, because this is what's seen the most changes over really not just 2025, over the last couple of years. It's a hot topic because everyone's always got questions and concerns about prescription prices and prescription coverage. And nowhere in our vocabulary do we ever use the word outstanding when it comes to Medicare Part D coverage. It is for some, just, some of you may be paying nothing, but it just depends on your situation, the medications you're on. Now, in 2025, the biggest thing everyone talks about is this $2,000 cap on out-of-pocket spending. So every plan has a $2,000 maximum out-of-pocket. There has never been a max out-of-pocket on Part D until 2025. There were some limits you would hit in prior years. There was not a flat amount, so maybe $3,000 to $3,500. But there is a true cap now. Understand moving forward, if that legislation stays in place, that $2,000 cap continues, it will not stay at $2,000. It will be adjusted up for inflation. So while we're not looking at, massive increases year over year, hopefully to that cap, it is going to gradually increase with the rate of inflation. And that is, by the way, for covered medications. So if you're paying out of pocket and the drug is covered, at some point you reach a $2,000 cap on total drug costs for the year, you're done paying. If that drug is not covered by your plan formulary, there is no cap, right? And not 100% of medications are covered by any means, as some of you already know. 2025 increased plan liability. So what does that mean? That means that the insurance companies and the pharmaceutical manufacturers actually have more financial responsibility. That is being shifted away from the members directly and the government and onto the insurance companies and the pharmaceutical manufacturers. However, that has impacts that are felt in other ways, right? And we'll talk a little bit about that, but it could have to do with premium or formulary size or models and cost while you're under your $2,000 cap. The elimination of the coverage gap or the donut hole, I had to put in donut hole there because a lot of us are familiar with that phrase. The donut hole is gone. So that was a portion of your coverage or a stage of your Part D drug coverage. And this, by the way, this is the same whether you're on Medicare Advantage with drug coverage or a standalone Part D plan. They've eliminated that. So like last year, for instance, you'd be paying 25% coinsurance for all medications while you're in that donut hole. And in some cases, that may drop the price of your drugs. In some cases, it increases them. Just depends on the retail cost. But that's gone. There's also a 6% cap on base premium increases. Now, I'm not going to dive into the calculation on that. It's really confusing, even to us, speaking this language every day. But just understand when you see that talked about or advertised or whatever, it does not mean that whatever you're paying today on your Part D plan, that you will only see a 6% increase on your premium. So the base premium is something that Medicare sets every year for the program. That's somewhere around $38 per month, right? So that's what the numbers they're basing off of, right? If you have a $30 plan or $38 plan, that does not mean it's only going to go up, $6, $7 next year because the plan themselves, they could increase that more than 6%. So don't be fooled by that number. And the new CMS demonstration program, which we'll dive into a little bit in detail here. But understand as we go into the next slide and talk about that, that is a voluntary program, meaning just because some of this stuff exists, it does not mean that your plan has voluntarily opted into it. So it may not apply to what you're on. All right, so Part D, premiums and market stability. So the base premium increase, again, it's a 6% cap on that. The couple of things I want to share with you here on these premium stabilization measures as well. So participating plans in the stabilization will apply a $15 reduction to the base beneficiary premium. So for some of you, you may have seen your plan drop to zero, or maybe a drop from $30 to around $15, things like that. So when you see a $0 premium or really inexpensive premiums, first of all, understand that the insurance companies are getting subsidies from the government, so they can afford to provide you a $0 plan. But for some plans, because they were already so low premium already, they dropped to zero. Doesn't necessarily make it the best plan for you, right? Zero does not always mean that it's right for everybody. Now, the limit on premium increases, so a cap of $35 was imposed on year-over-year increases in the plan's total Part D premium. So from 24 to 25, that means that a specific plan cannot have larger than a $35 increase. Now, number one, that's voluntary. Again, I need to remind you guys that you may have seen a larger than $35 increase because that plan could have opted out. What we also have seen is a consolidation of plans, less plan options. So one carrier, for instance, consolidated from 3 plans to 1, someone from 3 to 2. So the plan you were on may no longer exist, and then you saw a much larger than $35 increase because it's not the same plan, right? So even though these things are in place, there are ways around them, right? Insurance companies got to figure it out. So again, these are things you need to know. That's why we do the annual reviews, especially in relation to Part D, is because this stuff is confusing and it doesn't really necessarily apply to your situation or your plan in all cases. And essentially the risk adjustment model, so again, that just goes back to the fact that now, based for drug costs specifically, the bulk of the responsibilities on the insurance companies and the pharmaceutical manufacturers, less on the Medicare program and you as the beneficiary. So moving right along onto the numbers here. So look, $590 deductible. We get this question all the time because number one, it goes up every year, right? So that is the amount that you pay, where you are responsible for 100% of the drug cost before the plan kicks in. So if you're wondering why your January or February out-of-pocket costs are so high, and especially when you're on more expensive medications, it's because you do have to hit that deductible every year. Okay, so it resets in January and goes up in most cases. Now, for most plans, many plans, and many of you on here that obviously I know personally that we've worked with you, a lot of plans are going to exclude tier 1 and 2 medications from that deductible. So what does a deductible exempt medication mean? That means it does not apply to the deductible. So if I'm taking a blood pressure medication that has a $10 retail cost, I'm not paying the $10 because I'm in the deductible stage. I'm actually going to pay the tier 1 copay if it's a tier 1 drug. And on a lot of plans, that's $0 or $1, $3, $5, depends on the plan and the pharmacy. But so those tier 1 and 2 medications, you're just paying the fixed copay for those tiers. The tier 3, 4, and 5 drugs, which are your brand name and specialty medications, that's where you're finding these out-of-pocket costs early on in the year being higher because you have to hit your deductible. Again, that's not universal on all plans, but on many plans, tier 1 and 2 is exempt. Now, that initial coverage limit from the deductible to the $2,000, that initial coverage limit is where you pay a copay or coinsurance. So your plan will tell you tier 1, this is just an example, tier 1 is $1, tier 2 is $3, tier 3 is $50, tier 4 is 50% coinsurance, tier 5 is 25% coinsurance. Okay, so whatever that is on your plan, that's what you're paying for each medication in that tier until you reach that limit at $2,000. And then at 2001, you hit this catastrophic coverage stage. And in catastrophic coverage, you pay $0. So you have hit your max out of pocket at that point. For the remainder of the year, the drugs that you're on that are covered by your plan specifically, they will be covered at no cost to you. So let's talk about some of the plan redesign from the Inflation Reduction Act of 2022, things that have already been implemented, things that are new this year and coming forward, and some of the, quite frankly, the implications of these things. So for those of you on insulin, there has been now for a few years a $35 cap per month on insulin. Again, just like with any drug coverage, your insulin has to be on the formulary. So while we go through this exercise with you and we're enrolling initially, we're going through reviews, is because you hear this $35 cap, but is the insulin that you're taking on the plan formulary? And so sometimes there are alternatives. That's always a conversation for you and your doctor, and we can help, provide you formulary information, but not going to make a recommendation, obviously, on what medications you should take. But that cap is in place, which for those of you on insulin, that does help quite a bit because that stuff gets pretty expensive. No cost sharing for vaccines. So if you've been doing your flu shot, if you've done COVID vaccines, pneumonia, again, those things should all be covered at no cost. That cap on spending, I put it about $2,000, and I will explain that here in a minute because it doesn't mean that necessarily if you hit your cap that you've spent $2,000. Some of you will spend less than that, which we'll explain here in a minute. And then if anybody is eligible for extra help, which is a program, Social Security program, LIS is the low income subsidy, then they've expanded eligibility. So there used to be different levels and different percentage of subsidies, and basically everyone would get the full LIS versus having these different levels. Now in 2025, I've already mentioned this, so not to beat a dead horse, but that shift of financial responsibility. But going into that next point there on enhanced versus basic. So this is what we're talking about, this $2,000 number, and maybe you're not going to spend $2,000, but at some point you're going to stop paying for medication. So how does that happen? So this year we have two types of plans designs. There's an enhanced alternative plan and a basic alternative prescription drug coverage. And on the basic, you're usually finding those are the lower premium plans with typically the $590 deductible. So the majority of plans are going to use that $590 deductible. What that $590 represents is the max allowable. Some will have slightly lower. Most will have $590. And so basic plans are typically going to have lower premium, higher deductible, And if you hit your max out of pocket, it's because you have spent $2,000. So your money out of your pocket, $2,000 for medications, and then you hit that catastrophic level and you're done paying for the year. For those of you on enhanced alternative plans, those are typically your higher premium plans, and they oftentimes have lower or no deductible. So there is no 100% responsibility from you up to a certain point, and you just go right into initial coverage and pay your copay or coinsurance. What happens here, so going back to the shift of financial responsibility, is the insurance plans and the manufacturers are they're third-party payers, and they are making payments towards your out-of-pocket maximum. So for those of you that are on some expensive brand name medications, specialty meds, you may wonder why you're on a higher premium plan. Remember that when we do Part D reviews, we are looking at the net cost, right? So from January to December, what plan will hopefully provide you the lowest net cost when we add together premium plus your estimated drug copays? And that's where the higher cost plans are recommended. Because what you'll actually find in a lot of cases with this enhanced alternative plan this year is you might spend $500 and you've hit your max out of pocket. It could be $1,000, right? It's not a set number. It depends on your plan and your medications. But especially on expensive medications, it really brings down your out of pocket because that third party payments being made, 25% every month or every quarter you're filling goes towards your $2,000 cap. So it's what you're paying plus what the plan is paying, the government's paying, and what you're paying out of your pocket. So the good news is, if you think, well, why am I paying more and I'm still going to hit 2,000? You might hit the cap without actually spending that. And again, that's what we would have looked at for you in the fall if you did a review. So if you need a reminder, that let us know. And then copay smoothing is new this year. I'm going to cover that on the next slide. But that's basically a part of the program that allows you to spread out your drug costs. So for those of you that are hitting really high out-of-pocket costs early in the year, January, February, you have an option to go into this copay smoothing program, which I'll explain in a moment, which is going to let you spread those costs out over 12 months. And it's just because you aren't paying it all at once doesn't mean you're going to eventually spend over 2,000. You know, if those drugs are covered, that is your cap. You just don't have to pay it all up front if you opt into that program. And then coming next year and beyond, but coverage of selected drugs under negotiation. We will cover that list here. So in 2026, we will see that list of 10 medications that was negotiated last year. We will see the impact of that in 2026. And then beyond that, there will be multiple, like this year, right around now, actually, they should be in the process of that list being released for what will be negotiated next. So they'll negotiate that. We'll probably find out around September. And then those next 15 medications would go into effect, the negotiated prices in 2027. And then there's a couple of years beyond that where these negotiations will be seen. So Medicare prescription payment plan. This is the smoothing, the copay smoothing. So every Part D plan is required to offer this to beneficiaries. Okay. And whether you opted in when your plan information arrived or you do it now that you're in the year, but the program allows you to pay zero at point of sale and then pay off the out-of-pocket cost through equal monthly payments. So real simple math here. If you had a $1,200 drug cost in January, or let's say $1,100, and you wanted to have the payment plan, and you'd pay zero at the point of sale, and then you'd pay that $1,100 or that $100 every month for the rest of the year to meet that $1,100. Now, obviously, you're filling prescriptions throughout the year, so if you hit your max out of pocket, you've got more costs coming. But again, you can smooth that out so you are not coming up with that all out of pocket at one time. If you have questions about that, again, you should have received information from your Part D plan sponsor on this. If you have questions, let us know. Point you in the right direction to ensure that if you're being impacted by this and you want to reduce your cost up front here early in the year, that you can figure out how to go ahead and opt in. All right, now I showed the premiums earlier for Part B, I just wanted to highlight Part D. So again, if you are subject to income adjustments on Part B and you have a Part D plan, then yes, you will pay that adjustment as well. The thresholds are the same as $106,000 for an individual, 212 for joint filers. Anything under that, there's no adjustment. If your plan premium is the base at $38 and change, that's what you're paying to the insurance company, and that's it. If you're over that amount and you're subject to IRMA, you will pay an additional amount that goes directly to the government, anywhere from $13.70 a month all the way up to $85.80 per month more than your plan premium. All right, so we're talking about enrollment periods and the Medicare outlook as we move forward here. All right, so let's talk about enrollment periods. General enrollment. So there are some things happening right now, and they don't all apply to everybody. But just so you're aware, for you or family and friends, right? So general enrollment, no one on this call should have to worry about that because you all have Medicare Parts A and B, unless maybe you're sitting with a friend or spouse or something. And that's for people who missed their initial enrollment period at 65 and did not enroll or did not have a special enrollment period coming off of employer coverage at that time. So they can only enroll from January 1 to March 31st. That does end, obviously, in 10 days. So if you know anybody in that situation that they failed to get Part B in a timely manner and they will not be able to get it again until next year if they don't do it by March 31st and if they don't have a special enrollment period. Now, this may definitely impact some of you on the call, Medicare Advantage open enrollment. If you are in a Medicare Advantage plan to start the year January 1st, and for whatever reason, you don't want to be in that plan anymore. Maybe your doctors change, your medications change, you stayed in a plan when you shouldn't, you should have changed it, or whatever happened. You can still change that plan. You have a one-time election between January 1st through March 31st to make a change to Medicare Advantage. You can go from one Advantage plan to another, or you can go from a Medicare Advantage plan into a standalone Part D plan, which would put you back on original Medicare A and B. Just remember, Medicare supplement is always recommended with Medicare A and B, and this does not guarantee you access to a Medicare supplement. So you still have underwriting typically that you would need to go through if you're coming off of Advantage and into a supplement, but you can drop Advantage or change to a different plan. So if that's you, you have any issues there today or right now, this first quarter, let us know before the end of the month. Annual election period, of course, this is every year. This is when you hear from us most. We talk to most of you. Is that time of year, October 15th through December 7th. Those dates never change, and that is when you can make changes to Part C and D. So Part C, Medicare Advantage, Part D, prescription drug, one drug plan to another, which has been the most common thing because of all the changes to Part D. But we had a lot of changes to Medicare Advantage plans last year and plans leaving markets or really stripping benefits down. And that's the time to make a change. And whatever you do before December 7th is what goes into effect in January. So when you start hearing from us late summer, early fall, remember to respond to those messages and opt in to a review or tell us what you're interested in or what questions you have so that we're not left just leaving things where they're at only to find out later that was probably not the best solution. And then there are special enrollment periods that are ongoing. These could be things like weather-related disasters. That's pretty common. They're just a lot of multiple different things that can go on. It's all throughout the year. Just depends where you live, what's going on, what kind of plan you have. So they're not predictable, is the point. You can't rely on a special enrollment period, but they are ongoing. So if you are in a situation and you're outside of a normal enrollment period, like annual enrollment or Medicare Advantage open enrollment, then we can check if there's some option for you to do something outside of the norm. So this is that 10 drug price, or excuse me, that 10 drug list rather. So these are the first 10 negotiated drugs. The pricing will take effect in 2026. So I'll just cover these real quick. Eliquis, Jardiance, Xarelto, Januvia, Farxiga, Entresto, Enbrel, Imbruvica, Stelara, and Fiasp Novolog. So if you're on these, very possible you might be on an enhanced plan because you know how expensive these medications can get. but we'll see the impact of this in 2026, what that does to overall costs for beneficiaries who are on these medications. Hopefully, of course, a positive, which is what we'd love. But like all things with Medicare, I would take a wait and see approach, always cautiously optimistic. The impacts of changes to certain rules of Medicare and things like this, it just, it's TBD for the program. So we'll see. Additional outlooks. So here's what we already saw in 2025. We saw increased Part D premiums. Some of you have felt that directly. Certainly expecting further increases. And this is, I'd say, more on the standalone Part D side. So if you're on a Medicare supplement, you have a standalone Part D plan, we are expecting an increase in premium. So as long as there's a cap on out-of-pocket expenses and more financial responsibility on the side of the insurance companies, again, they're going to figure it out. So increases in premiums would be expected. Stay tuned. Fewer plans, we've already seen that. I already mentioned it earlier. There was some consolidation this past year where some companies went from 3 to 1 or 3 to 2. And this has been happening the last couple of years. I think when I joined, got into this business 6 years ago, there was maybe like 20 to 30 plans, probably 25 to 30 plans in most markets. And a lot of places this year is down to about 15 or so. And that does vary depending on where you live. But we've already seen that impact over the past couple of years, and I would expect it to continue. Remember, these insurance companies do not have to offer Part D benefits. So if they decide it's not worth it, they can just pull out of the market. And then thinning formularies, right? So again, there are certain requirements insurance companies have to meet for coverage, but they don't have to cover everything. And if there's a particular drug class, they don't have to cover 2 medications, and maybe they'll just cover 2 instead of 4 or 10. And so we're already seeing some of this stuff happen where there's less things covered. What's not mentioned here, but has been seen a reality this year, is that we see more things moving, let's say, from tier 3 to tier 4. In a lot of plans, you might have like 25% coinsurance on tier 3 and 50% on tier 4, or $47 copay on tier 3, 50% coinsurance on tier 4. And so insurance company can just change the drug tier in some cases, right? And 50% coinsurance probably going to be a lot more than 25, well, obviously more than 25% and more than $50 for these expensive drugs. On the Medicare Advantage side of things, I would expect a return of more robust extras. We definitely saw a pullback in 2024. So we were getting all sorts of crazy last minute notifications about plans that were no longer being offered. They're pulling out of the market. They're cutting broker comp and contracts, and it was kind of a wild time last fall. So we did see a pullback. We saw a lot of plans that they just increased their max out of pocket. They may have come in really aggressive in years prior with low max out of pockets, maybe a lot of extra dental, vision, hearing, over the counter, all these extras, which are great. It's not ever the primary reason to get a plan, in our opinion. But we just saw a pullback just across the market. I would expect those extras to return a little bit. I don't know to what extent. Again, it's always wait and see. But if you're in an Advantage plan, I would be looking out for that in the fall. Increasing out-of-pocket maximum exposure on Medicare Advantage. So this is nothing new. That's just how it is. Every year we see an increase in max out-of-pocket. So this year it's $9,350 is the max allowable for in-network. So I'd expect that to continue rising, which ultimately for those of you on Advantage is a larger increase in your exposure. And there'll be definitely, we've already seen a little bit of this rolling back of regulations. There's certainly multiple outcomes that that can come out of that. Some good, some bad. For us, maybe a little bit easier to do business with you. Not all these, recordings and limitations on when we can talk to you, and disclaimers that make our conversation robotic. Those would all be good things. But also, you could open the door for more people to be trying to take advantage of Medicare beneficiaries. So always be on the lookout. Be skeptical of anybody calling you or sending you mail about some extra benefits or free food and groceries, or all these crazy things you see, because that's not the government. They look like government documents, but they're ads. And you just got to be careful, of course, who's out there. There's a lot of great agents. We're not the only ones out there, of course, but there are a lot of bad apples too, unfortunately. enough at least. So planning for the unexpected. I'm kind of a little behind here, so I apologize. I'm going to move along. So look, now more than ever, with some of these changes to Medicare Part D in particular, we expect tier three through five drugs to cost more co-insurance, or plans leaving the market, and just more of a likelihood that if you're on those kind of medications, you're going to hit your $2,000 cap. Okay, so more people hitting that. So again, it does help some of you who are paying more than that. Those that were not may not pay anymore, but we think we're going to see more people who are going to be paying closer to $2,000. And again, if you're on things like we're talking about cancer, heart attack, and stroke here, where you wind up on very expensive medications, that's typically going to be for, not just a year potentially, right? So you might be on these drugs for quite a while, paying $2,000 annually. Now, with the thinning formularies, all right, our concern is also that there will be things that are not covered, which means there's no max out of pocket, right? So if the insurance companies are leaving the market, if they're deciding to cover less medications, that means less coverage for you on these expensive medications. And so some things that are exposures that you're going to be potentially facing for diagnosis of cancer, you have a heart attack or a stroke. Again, those covered medications up to 2,000, and then the uncovered medications with no max out of pocket. That's a big exposure we're worried about. We've been seeing it a little bit this year, and just kind of expect that to continue. For those of you on Medicare Advantage, 20% co-insurance for things like chemotherapy and radiation. Okay. So if you're on a supplement, you're pretty well protected from traditional chemo and radiation. On a Medicare Advantage plan, you do have a max out of pocket, but you're still paying 20% up to that amount, which if that's $9,000 and you're 2 years in a row, you have to continue 2 calendar years with treatment. It's quite a bit of exposure financially. They're also, not everything's going to be covered on that front. So if you have a non-traditional or experimental treatment for something like cancer, those things are not necessarily covered by Medicare. And then, of course, there are non-medical cancer costs that we hear a lot about. They account for up to 42% of all costs associated with things like cancer. Could be travel or lodging for treatment, wigs, cold caps, home and lifestyle modifications, and home health aid. So not home health care, but home health aid. This is custodial care. Maybe you need assistance at home to perform certain activities of daily living, whether that be from cancer, heart, or stroke, or anything else. And that non-medical care is not treated or not treated full, or not covered rather, and not covered full time. Okay, so these are some of the exposures that, yeah, your plan will cover some of these things, but not everything. And then it's whether or not you want to cover that yourself, to self-insure and pay out of your pocket, or to cover that through a cancer, heart, or stroke cover. So some of these things I'm going to talk about here in the next few minutes, we have not always done the best job of talking about them with our clients. Number one is they weren't always all around. And in some cases, it's the state you live in, right? So not every option is available in every state. So sometimes there's just not a product available, but also just not necessarily knowing what's out there to reduce your exposure to these types of things, right? So cancer, obviously, everyone knows someone or has had it themselves. And so it's a very high rate of diagnoses, much higher for those over 50. So we do recommend cancer coverage for Medicare beneficiaries moving forward. There are those out-of-pocket expenses that are non-medical, as well as those, in particular, the drug costs that I get concerned about that are going to exceed the $2,000 because they're not on the formulary. So if that's something you ever need to talk about, we are happy to do that. It's not these types of things on the reducing exposure side. These indemnity products are not subject to annual enrollment. So if it's something you need to talk about sooner, we're happy to cover that. Let's cover home health care and skilled nursing exposure. So again, days 1 through 20, Medicare pays. So on traditional Medicare and a supplement, you pay zero. If you're on a Medicare Advantage plan, you may or may not be charged copays. It depends on your plan. A lot of plans do cover those first 20 days. They do not all. Days 21 through 100, $209.50 per day, which is about $16,000 if you're in there for 100 days. Now on Medicare Advantage, you'll have a max out of pocket that you'll reach before then, but you are subject to those copays up until your max out of pocket. Again, on a Medigap or Medicare supplement plan, you are very well covered on those next 80 days as well. So nothing to worry about necessarily there. But then after day 100, all costs are on you. Okay, so unless you were to have, let's say, a long-term care policy after day 100 that kicks in, you have no coverage after day 100 in skilled nursing. Additionally, Medicare requires a 3-day hospital stay, excluding the day that you're discharged, to qualify for skilled nursing coverage. Okay, they're going to first of all require that. They're only going to cover semi-private rooms. So if you want a private room, you're not covered for that. And then on home health care, home health aid rather, it's only covered intermittently if medically necessary home care is needed. So if you need full-time home health aid, because again, you cannot perform all activities of daily living like eating, dressing, bathing, toileting, those kind of things, or you need someone to come in the house and help around the house, that custodial care is not going to typically be covered, or if it is, it's intermittent, only if you're receiving home health care. So again, another thing that we are talking about and is becoming a lot more widely available is home health care and recovery care. So we do recommend these things as well. They pick up where Medicare stops, and even including for those of you with long-term care policies before those benefits kick in, because you may or may not be familiar with your long-term care policy, but there is an elimination period typically, usually 90 days is pretty standard. So you have to be unable to perform activities of daily living for 90 days. Well, what happens in between there, right? So maybe your Medicare and your supplement will pick up some or all of that. If you're sent home from the skilled nursing facility before 100 days or you didn't qualify, right, there's a gap there that you should be looking to fill before that long-term care kicks in. So these are shorter term recovery care benefits and home health care, which include home health aid. Again, the benefit being where Medicare does not cover you for needing help with activities of daily living, a home health care policy kicks in and helps out. And some of those even reimburse for prescriptions, which can help to subsidize your premium. So they're pretty attractive. Again, those were not necessarily available in a lot of states up until pretty recently. But as they become more widely available, and especially as they provide this prescription reimbursement, we're heavily recommending looking into those as well. Last couple things here, hospital costs. This is primarily for those of you on a Medicare Advantage plan. Again, if you're on a supplement, you're pretty much not going to have any hospital costs, right, for Part A, because your deductibles covered, your copays are covered, you got a 365-day extension. But on Medicare Advantage, you typically require a per day copay for a set number of days. So maybe that's $300 a day for 7 days. Well, that's $2,100 for the admission, not including whatever doctor's visits, tests, surgeries, treatments you're getting in the hospital. Medicare also typically only covers semi-private rooms. So if you were really set on a private room, you would not get that through Medicare, whether it's an Advantage plan or a supplement, unless it was for medical necessity or there was no semi-private room available. But those hospital protection plans, again, in particular for those on Medicare Advantage, provides the cash benefit, which is going to be used to help pay for those admission copays or private room costs. All these things are cash benefits, right? So you get a diagnosis, you go to the hospital, you have skilled nursing, you're getting a check from the insurance company to help you pick up those costs. And then finally, this is more, of course, for those on Medicare supplement, because you Advantage folks, your plan probably has some dental, vision, hearing, maybe limited, but it's usually there. And this is not the biggest exposure we're worried about. We're a little bit more concerned about cancer costs and skilled nursing and home health aid costs. But if you have, some significant dental work, let's say that's expected, then a dental plan can certainly help. Hearing as well, hearing aids are not covered by Medicare, so that's something that you are in need of or may be in need of. Again, there are ways to reduce your out-of-pocket costs. You worked hard all these years. There's no reason for you to have to go into your pocket, your savings, your investments to come out, because a lot of these plans are going to be a lot more affordable than you may think, to help cover these things that, some of which are of course very common. So try to zip through that a little bit because we're running out of time. So we're here for the Q&A. I'm going to go ahead and pull up the Q&A. I saw someone raise their hand too. I don't think I can let anybody talk here. So if you have a question, drop it in the Q&A. Got a couple people who need the newsletter. Awesome. We will take care of you. Yeah, we have a message from Michael here. Appreciate it. I get calls all the time from Advantage plans. They all have my information. And how can I protect my info and make the calls stop? Yeah, so I wish I had a great answer to that, because I would certainly share with every client and every potential client that we work with. I mean, it used to be, well, hey, just add your name or your number to the do not call registry. But if you're thinking about the people that are calling you, it's not even the Medicare Advantage plans. A lot of times these are offshore call centers. They don't follow our laws and our rules here. And they don't care whether you're on the list or not. And they may say they're calling from XYZ insurance company. They're not. They're just trying to push that plan. All they're doing is trying to get you into something. They're not going to check doctors and drugs, and it's all churning of policies, right? So I wish I had a better answer, Michael, on how to stop the calls. But quite frankly, even if you add them to a do not call list, doesn't necessarily work. I did hear about an app, a smartphone app. I think it's called Robo Killer. I do believe it's a paid app. But you may look into that to screen those calls and just kill the call. So maybe that doesn't stop the calls coming. Maybe it screens them though. So I'd be looking at stuff like that. I don't have the perfect answer for you, unfortunately, on that, but it is a good question. So we have a question. Does any of this apply to me? Again, if it's in particular, if it's case by case basis, just like we would do when everyone here is joining Medicare, we're not going to provide a blanket recommendation to everybody. So does it apply to you, Catherine? Again, everyone's situation is different. I can follow up with you afterward and then let you know if it applies to you at all, but it may or may not. Again, everyone's got a little bit of a different situation. How do they get your info, Michael? So it's a good question. I mean, data is a big business, right? So if I wanted to go out and buy a list of people who are turning 65 this year, could do that in an hour, maybe less, or people that are already 65. So unfortunately, your data is out there. Again, I don't have the answer. I'm not a specialist in that arena, but data is big business, right? People are selling data all the time. So how do they get it? I mean, it's out there and they've got their ways. Carrie, you need to make an appointment. Yeah, reach out, let us know. We can definitely talk about some of this additional coverage, reduce that exposure. So shoot me an email. Mari, you're late. Can I get a recording? Yeah. So anybody, as I mentioned at the beginning, whether you came in late or you just want to rewatch and go over this stuff, read your notes, this is being recorded. We will send out a recording of the webinar today so that you have an opportunity to watch it or rewatch it. Good question here. I'm going to not necessarily give you the answer you want, but in your opinion, which state provides the best options for seniors on Medicare? Yeah, I can't answer that. I mean, it really depends because, again, first of all, are you going with Medicare Advantage or Medicare Supplement? And there are certainly states that are more Medicare Supplement friendly and others that are more Medicare Advantage friendly and not so supplement friendly when you look at the premiums, right? So it's a little bit more too nuanced for me to answer on a call like this. Depends on your state. So if you want to ask that question for your particular state, or maybe you're thinking of moving, again, we're happy to talk about that with you and see if somewhere that you're thinking of moving is going to be a little bit more friendly potentially, but no generic answer there. We've got a question. One of my meds is not covered. So please send us an email, listen to or reach out. We'll take a look, find out what's going on there. Again, this is, as I've been talking about the entire presentation, not everything is covered, right? And sometimes there are certain things that are not covered by any plan. Now, for those of you who may have a drug that's not covered by any Medicare plan, or you go on a medication once you're already in your plan for the year and it's not covered, there is something called a formulary exception. Your doctor will be familiar with this process. They would submit that formulary exception to the insurance company, who's required to turn around and answer in 72 hours. So that is an option for you or anybody if you have something that's not covered. But if you're in that situation, we can always look at it and see, hey, there's no plan that covers it, or maybe you're in a plan that you're able to still change. An SEP might be available. So Lucinda, you can reach out to us specifically on that medication. Hey, good question here, Glenn. I'm kind of expecting this. So are federal government layoffs causing delays in processing Medicare claims? Not that I have heard of. Still early. I don't know. But I'll tell you this, I haven't noticed anything like you would expect. People that are going on to Medicare now that are applying through Social Security, maybe there would be delays. I've actually, and again, this can vary depending where you are in the country, no matter what's going on, whether it's this administration or the last, where some offices are really good and some are terrible. Um, and so it just depends where you are. But I have not actually heard any increase in delays of enrolling into Medicare and getting those applications processed. And haven't heard of any claim issues processing claims at this point. So it's a great question. We're always ear to the ground, pay attention to what's going on. But so far, I have not really seen anything for you, everyone here on Medicare, that is in a short term negative. I don't think the Medicare program is going anywhere, so I wouldn't be too concerned about that. Again, I think everything, at least for 2025, that you've got set up, like you're not going to experience much difference here this year. But again, like with every year, it's always important that we talk about coverage in the fall. It's for me, and for us, it's more about just understanding that. There is legislation that's already in place that is potentially impacting your exposure, right, in the long term. And that's what I would say, most concerned about, more that long-term exposure, but nothing necessarily new from the last couple of months. Got a question here. Brian, are you available for a consultation on my personal health care insurance and Medicare coverage? Yeah, that's what we do. So reach out if you want to chat about your coverage and your options. That is exactly what we do. We are working one-on-one. My team and I meet with one of us and talk about your situation, right? Whether you're new to Medicare or not, and understand what your timelines are and what your coverage needs are. And then we will make a formal recommendation on what umbrella coverage to go ahead and recommend, and then help you get that started and ultimately service those policies. Anonymous, okay. Do you foresee any other changes to Medicare coming from the new administration? Yeah, I mean, I'm not a fortune teller, and I don't mean to, brush that aside. I don't know. So changes, yes. I mean, every administration has changes. Medicare is always going through changes. Right now, whether they're going to be full-scale changes that are going to have a huge impact on you today or this year, definitely don't think that's the case. Next year, following, again, I don't have a doom and gloom outlook on it, I guess would be my best answer. So I wouldn't be overly concerned, but we're all in the same boat, right? We're all impacted by this program, whether it's us as your broker or yourselves as beneficiaries. And so whatever does change, we are staying in the know. We are here to help. And that is why, if you need an annual review, we highly recommend you set one up when it comes to time. Again, you'll hear from us like August, September, to get a gauge on where you're at. And that would be the best time to connect on what's the future of Medicare. We can only do this 1 year at a time. So that's my answer there. So it looks like, I think, from a question standpoint, that's all we got. Please dump them in there if you're still here. I've got a couple more minutes, so I'm happy to answer more questions. I love this part of it. So if you do want to discuss any of these things we talked about today, again, when we have set up your coverage, we set that up initially, right, to be the best for what is your needs and your wants. Since there are exposures there based on whether you qualify for things like skilled nursing, or you need home health aid, or formulary thinning for expensive cancer, heart, and stroke medications. These things have changed a little bit. If you do want to discuss any of these things, email your agent to discuss. I'm sure most of you on here or I'm your agent, but if you have worked with Lisa on her team, just email your agent to discuss this information, or just questions in general. It doesn't have to be about umbrella coverage, but just reach out as always when you have questions. We are here to help. Look, we work for you. As I mentioned earlier, we work for you, not the insurance companies. So, our goal is to keep you as a client for the rest of your life. Okay. And it's a win-win for both of us. Got another question here. Robert, thank you. Does long-term care insurance still make sense given Medicare's coverage? Yeah, absolutely. I would never tell someone to cancel their long-term care insurance. So understand, Medicare does not cover long-term care. So let's run through a hypothetical situation, right? You go to the hospital for whatever reason. You break a bone, have a stroke. Okay, go to the hospital, and you're in there. And if you're in there for 3 days, not including the discharge day, then you can qualify for Medicare to cover skilled nursing. Okay. Now that long-term care is not a factor at that point, right? So if you qualify and you go to a skilled nursing facility on a Medicare supplement, which, Robert, I know that you're on, as long as you're able to stay in that skilled nursing facility because you show improvement or maintaining of your status, which by the way, just is not always uh, line up with the truth. Okay. We have a family history of experience with that where, they're just trying to get you out of there. Right. And so just because you might think you're improving, your family thinks you're improving or maintaining, doesn't mean that the skilled nursing facility agrees. It doesn't mean that Medicare agrees. Right. So don't just assume you're good for 100 days because that's what Medicare can cover. However, if you qualify 100 days, you're good to go. You still may be discharged and go home and need uh, health aid, which is more custodial care, which again, Medicare is not covering, or if it does, as I mentioned, it is part-time intermittent coverage. But long-term care makes sense, Robert, because let's say you're in that skilled nursing facility for 100 days. And at that point, it's really a long-term care situation if you need the care. And we're talking, the health, the home, the skilled nursing care and the home health aid. Well, long-term care policies typically are going to kick in, like I said, usually a 90-day elimination period, up, give or take. And so then it would kick in, and you wouldn't need that because, as I mentioned earlier, Medicare does not cover over 100 days. Now, for those that don't have a long-term care policy, whether it's because you don't feel like you can't afford it or it's not worth it, or you can't qualify, there are shorter term recovery care options that can pay you out, $170,000 and twice in a lifetime that can really help to cover the cost there in the event that you don't have long-term care or you need that care before your long-term care policy kicks in after the elimination period. So definitely would not ever encourage you to cancel your long-term care policy. I'm not a long-term care specialist, so I mean, I can look at these policies and give you some thoughts and see if there's anything else that may be needed. But whoever got you that policy is who I would talk to about it. But they're valuable policies. It's just I don't know what you have, what you're paying, when you got it. Is it a hybrid with life insurance, which a lot of them are now? So don't go cancel anything, but feel free to reach out with more questions about that. Again, happy to take more questions as they come in. While I'm waiting for any additional questions, there's a thank you for joining us today. And many of you have probably seen this. I don't blame you if you have not read it. I would not be hurt by that. It's not a bestseller. It's not the most riveting of reads. It's good maybe for before bed, put you to sleep, but this is something we put out every year. So it's, I don't know, 60, 70 page book that I put together called Medicare Breakdown. So the 2025 version is available, and it's gonna have some of the information from here today, the cost. Most of the information doesn't really change in terms of Medicare specifically, but it's a good guide. So we'll send you all a PDF copy for those that were here today as a thank you. If you want to share that with friends and family, again, you can forward that right along. We don't mind at all. The more the merrier, the more people we can help, the better for everyone. So we will go ahead and send that out to you for being here with us today. If you do need to reach out, then you have my email. That's the phone number to our office. You can call the office. You can email me. Kara, I do see your hand is raised. I don't know that I can do anything except for answer questions in the chat. Quite frankly, I don't believe that we have the option to let me see, allow to talk. All right. So if you do have a question, Kara, feel free to hop in. You are unmuted. Not sure if that was intentional or not, but I guess I can do that. And if anybody else has a question they want to ask live, raise your hand. Learning things here too. I'm a Medicare specialist, not a Zoom specialist. So I try to stay in my lane as much as possible. I'm learning. Accident. Okay, no problem. I figured as much. Let me turn that off. So look, folks, if you have any other questions specific to your situation, some of your questions obviously are, please do reach out. If there's anything we can do for you or your family at any time, let us know. Send folks our way. If you want to talk about the umbrella coverage with your agent, just reach out. And if nothing else, reach out in the fall. Annual enrollment reviews are always recommended. And with that, I would just say, I'll have a great weekend. Go Maryland Terrapins. I know I got one of my favorite clients on here rooting for them, myself included. So 4:30 today, let's get that juju going. Enjoy basketball, enjoy the weekend. And that's it for me. So I'll stay on while you all hop off. So if anybody does want to throw in a question at the end, let me know. But I'll be here and just looking forward to continuing to work with all of you for many years to come. Thank you. All right, folks, I'm going to hop off now. Looks like no other questions. So again, thanks so much. Have a wonderful week. Oh, sorry, I do have a question. Apologies, Wayne. So you will email us the recording of this session? Yes, Wayne. We have been recording. We will email you a recording probably next week by the time we get that out. But stay tuned. So that and the PDF of the book. Thanks for coming. All right, folks. I'm signing off. Thanks again. Have a great weekend. Everyone, take care.